Hi, everyone. Welcome to another VITA Academy webinar. Today we have Mr. Peter Peasy. Peter, how are you?
I'm doing good, Jim. How are you?
Good, good. So we've got you today. We're going to have you talk on the envelope of function, a concept in which I think you kind of have built on a lot of your different subject matters, and I think it's a topic that is well deserved to be talked to, for the customers and so forth. So thank you very much for joining us today.
I'm getting some coffee because you always take a long time anyway.
The program itself is going to be recorded. We post these a couple of days later on our website, VITA North America YouTube channel. So please visit when you can. It's got all of Peter's last year's and this year's current webinars that we've recorded, different subject matters. I think they build on each other, so this gives you time to review it and say, hey, what did Peter say? And you can go back and review that. Anybody that's going to ask about CE, the information that you sent into us to register, we will use that for your CE information. So please go ahead and make sure that you sent us your correct information. If we have your CDT number, we'll use that. If not, you'll need to give that to us. We will submit directly to NBC, or if you're in Florida, the CE broker and so forth. So today's topic is going to be understand the envelope of function concept. Peter, I have to admit, I didn't put my your CV in front of me, so I don't have it in front of you. So
that's better. That's better.
We'll make it quicker to get to
that's
you.
Even better.
So I'd like to introduce Peter Peasy, outstanding friend of mine that I've learned a lot personally from Peter. I must say I enjoy working with Peter. Peter, I learn something from Peter every time I listen to him. And it's really gracious of Peter to provide real education, not just, hey, look at my cases. Peter actually shows you how to do it, what to think about, and how to present your case if you're trying to achieve a better status and a better cosmetic dentistry. So, Peter, I'm going to turn it over to you so that you can show your screen.
Well, thank you, Jim. I appreciate the nice words, and yeah, it's mutual on both sides. I enjoy working with you and your thoughts, and I've learned a lot of things from you over the years. And in truth, you pick a lot of these topics, as I think I always say, and people know. So I kind of find it like almost a fun challenge that you hear things that I say and make it a topic, and then I go home and I have to figure out what that is and how to utilize it. So this topic, the occlusal envelope of function, I think is a great one. And like I said to you before we started, last night when I was organizing some things, I thought, oh no, what am I going to talk about? And then this morning I had 200 and something slides and I had to get rid of most of them and try to condense it down. So let me dive right in and tell you that I think, occlusion is something that we really just don't speak enough about in our profession. We spend so much time on how we make things look pretty that I think a lot of times we forget that nothing really works without understanding the functional envelope and how we look at it. So let me start by saying, for me, I have a basic system, and that system is really, first off, where do the teeth belong in the patient's face? And I think it's really a denture concept more than a crown and bridge concept, and I want to be clear that they really overlap a lot more than we're probably aware of. I think, years in the past, the denture people were them, and the ceramists were them, and they didn't really have that same interaction. And today, and I've said it for years, in order for you to be a viable technician, you need to have more skills. So when you look at a face, you're really looking at the face and saying, do I like where the teeth are? Or what if she had no teeth at all? Where would I put them differently? So that's to me about a facial position. Then I want to look at the aesthetics of that facial position. Are the teeth in the right harmony with the lower lip? Do we have the right length that we want? And then after that, I'm going to start to look at the pink aspect of it. Does the patient show pink or do they not show pink? And each of those aspects are really how I start almost every case that I work through. Basically, the face, the white, and the pink, you guys have all heard me say 8 billion times. And then again, I kind of treat this like a denture. I pretend there are no teeth in the mouth, and I want to idealize what it is. So I say think denture across the board, whether you're doing crown and bridge, or you're doing aesthetic veneers, or you're doing full mouth rehab cases. Think denture, because it really makes us think a lot better about how we do that. And here are the keys when I'm setting up a denture or I'm setting up an aesthetic functional case. One, where does the incisal edge position belong? IEP, incisal edge position. Once I determine that, and let's be clear, and I've said this before, you may see things differently than your clinical partner or whoever you're working with, meaning that you want a longer incisal edge, somebody else wants a shorter incisal edge. And a lot of times those little disagreements happen to be over a half of a millimeter or things that are minute. So in this case, it's really about an aesthetic preference of where you like to see the teeth in the face. Two, once you have the incisal edge position, that really determines what your gingival position is. We all know that the average central is about 10 millimeters, 9.5 to 10.5. And we know that once we understand where the incisal edge is, now we know where the gingival tissue should be. So that kind of gives us a plane of reference. It also gives us the horizontal position of where the rest of the teeth should be. So everything is really established through that IEP. Once we understand the upper arch, the incisal edge position, the horizontal plane, then we're coming back and we're starting to look at the lower incisal edge position. And this is really what we're going to kind of focus on in this webinar today, because I think when we talk about occlusion, we talk so much about anterior guidance and different functional capabilities. We don't really talk enough about the lower incisal edge position and how it relates behind the maxillary anterior teeth. And that's a real important part of the restorative process. And then once we've established that, we'll go into the horizontal plane of the lower teeth. And this is where the bilaterally balanced occlusions come in, which I'll explain a little bit more as we go through. So that's how I start everything, is kind of looking through that and deciding where I need the teeth to be and what I want them to be. And let's think here. This is a patient that's presented to us. When you look at a patient like this, I think, again, the first thing you should be thinking is step one, where do his teeth belong? Now, we can obviously look at the mess of mouth that he has going on here and say, wow, full mouth rehab, what material do I want to use? How do I want to restore it? But none of those things are really critical until I start to establish the functional and aesthetic parameters. So step one, where do I want the teeth in his face? And I'm walking on the 8 and 9, the incisal edge position of those teeth. And the reason that I'm doing that is because that incisal edge position is what's going to determine everything else for me aesthetically and functionally. Then I'll work on the horizontal plane, where I want his teeth to be in the horizontal plane, and that'll also give me the gingival position. From there, I'm going to go to the lower incisal edge and understand where that should be from a functional point of view, and then that bilaterally balanced posterior occlusal plane that'll match up to the upper across the arch. So I assume as you guys are watching this, you should be looking at this and saying, you know what, I actually might like the 6, 7, and 8. I think they're kind of okay for him. And I think the 9 is too long. Other of you might be saying, I like the 9 where it is, and I want to lengthen the 6, 7, and 8. Again, those are kind of preferences for your aesthetic needs. But I base that on the patient's age, the lip dynamics, where I think the teeth should be. And I try not to let the lower influence me at this moment, meaning that obviously I want those lower teeth shorter, but I'm just kind of masking them out. I'm almost pretending they're not there. And I'm just looking at what the upper arch should be or shouldn't be. So we can compromise and say, maybe I want to get a little more length out of the 6, 7, and 8. I'll take the 8 as a reference. And do I want to go as long as the 9? Let's split the difference and say somewhere in the middle of those things. But also I have to be aware of lip support. Not only where I want the incisal edge, but where I want the position of that 8 and 9 be. And that's going to help me determine whether this is going to be a crown and bridge case or a denture case, or how I'm going to actually work through this process to help this patient to have what he needs, both aesthetically and functionally. So I'll jump to the chase and tell you that this case is going to be an all-on-4 type case, or an all-on case, as we call them today. And we did our normal verification jigs, our normal IBJs and impression taking technique. And what I'm really looking at in this scenario is, where does this patient classify? Is he FP1, FP2, FP3? And for those of you who aren't familiar with that term, what that actually means is FP1 would be that we're only really restoring the white part, the teeth that his gingival and bone architecture is in a good enough location where I could just manage the white part of the restorative. FP2 is a little bit of a question mark. We may be able to only manage the white, but I might have to have a longer tooth that I might like. Maybe it's 11 millimeter or 12 millimeter central. And in some patients, that's fine. In other patients, it's going to need some pink incorporated in there. And then FP3 would actually be that I really know right away this is going to be a white and a pink case for restorative. And on him, I'm pretty sure that he's going to be white and pink because of the fact that he's lost bone. It's an implant case, and we're going to be restoring both sides of the arches. So I'm going to start off by doing a diagnostic wax up, evaluating my premise of where I would like the incisal edge to be, and then I can come back and make the determination if he really should be, you know, F1, 2, or 3. And in this case, he's definitely not F1. He's either going to FP1, he's going to be more FP2 or FP3 based on what I'm looking for in the final lip support and the incisal edge position. And let me be clear about this point here, because I could theoretically leave him where he is, which we would say is more of an FP2, more white. But what I don't want is I want to make sure that when I evaluate the lip dynamic, that when he has a bigger smile, I don't want him to look like he has 15 millimeter teeth. So I already think that he's going to need some sort of a pink. How much pink that's going to be is going to be determined by the lip dynamic that I use. So once we have the wax up determined, and we're going to start doing the setup for the final restoration, you can see at this point I'm incorporating pink. And if I go back between the two slides, take a look at his lip support in this photograph with my provisionals here. You can kind of see that under the nose, the lip kind of collapses a little bit. And if I go forward and we look at that same lip in a denture, now you can notice that that lip has a little bit more support to it, which is really what we want. So what does that mean? I'm FP3. We're going to do a digital design on this, right? So we'll do our digital design bar after the setup is done. And this is obviously not going to be a crown and bridge case. This is going to be a denture case. It's going to actually be an MK1 case. We'll design the dentures, finalize them, and then make everything so that we have it just the way we want it to be. And in the end, he is truly an FP3 type case. And I think you can see the restorative works well for him. Also, to be clear with these FP3 type cases or any of the pink cases, I've said this in other lectures, usually the pink is about 30 to 35, almost 40% of the white. So anytime that a tooth is getting longer than 9-10 millimeters, if you don't have gingiva supported, you really have no choice but to go pink there in the final restoration. Okay, we also talked about in other lectures fluorescence of teeth. Now, in this particular case, this has nothing to do with fluorescence. I only wanted to point out to you that even in quality denture teeth, and these are the VITA teeth, obviously, you'll notice that they've actually incorporated fluorescence into the denture teeth, which I think is really cool, because just like in crown and bridge world, we're trying to make everything look as natural as possible. So I think that's really important for us. The other thing that I do a lot of is I don't really, if I'm doing denture type cases, obviously if I'm doing crown and bridge cases, it's easy because I'm controlling the aesthetics and my ceramic layering and my colorations and translucencies and all the things that I want to do. When I'm in denture world, I don't really have that luxury because the tooth is already kind of predetermined. So rather than leave the tooth that way, a lot of times I'll come back, and after we're all finished with the denture, we'll come back and we'll do a little of the LC stains on that. So I'll sandblast the entire case, and I'll colorize, maybe create some more mamelons and some more warmth, as you see here in the middle thirds, and some coloration at the proximal. And even on the pink, I might want to kind of add a little coloration to the pink, just to make it look a little more realistic. And that's kind of a standard for us when we're in the denture world. And this would be just an MK1 type bar case. So in the end, I think you can see that this is not my typical layering and here's all the layers that I want to do. This is a denture case. And yes, we do those cases. And as we're working through those cases, we're thinking of everything from the aesthetics to the functional parameter of how it works in the stomatic gnathic system. And this is really important for us to kind of start to understand, because this system, the stomatic gnathic system, is really an amazing process. There's so many things about it. It's probably the most complex system in our body that we treat like it's just bone and teeth, but realistically, it's one of the more complex systems of how it all works together, from the joint to the muscles to the teeth to the guidance, and all these things work so well together. And really what makes them work together so well is something called proprioception. And proprioception is really a fluid-based response system. So the best way I can explain that over a period for people to understand it is, if I take my finger and I put it over the oven or a flame, my brain interaction will start to feel the heat at a certain point. But believe it or not, I can actually get burnt before that signal really kind of warns me how much danger that flame is causing to my skin. Why? Because it actually has to go through a nerve path to get up to the brain. Well, it doesn't work that way with teeth. Teeth actually have a proprioception, which is a fluid-based response. And I think you guys start to see that when you bite on something that you shouldn't, right? You bite on a piece of tinfoil that was in your food by mistake, and you instantaneously know you can't put any pressure on that. And that's a really different system. And the reason it's a proprioceptive system is because this muscle can provide over 1,000 pounds of force. And if we didn't have a proprioceptive response, what would happen is we would be breaking our teeth left and right because the forces are so are generated so quickly. So we really need a very sensitive system. The example I've used for this, teaching occlusion over the years, is my favorite is M&Ms, right? Think about the concept of biting an M&M. You take a hard outer shell, you put it in your mouth, and you bite down. Now, how does your brain know that it's a hard surface and they have to kind of bite harder to break through it? But instantaneously, the thickness of that hard candy shell is microns, right? It might be not even a full, 40, 50 microns of shell. Yet, as soon as you break through the shell and you hit the soft chocolate, your brain knows. It doesn't have it has the ability to stop you from really keep crushing so hard, because it realizes now the next item that's there as a chocolate is softer. And that's really incredible if you think about that, right? And if you really want to make it more complex, how about we take the hard and soft shell that we have here and switch it to a peanut M&M. Hard shell, soft chocolate, and then a peanut inside. How is it possible that your brain has the ability to break the hard shell, apply less force when it gets to the chocolate, and more force when it gets to the nut? And boy, that's an amazing process. And that process that we have is really what separates this system from any of the other systems in our body. So let's look at the way we kind of define how this system works. For us, it's been occlusion that we've always kind of basically our general term for how it works. But there's really three parts to this. One is maximum intercuspation. And this is really where, when we're talking about how the teeth kind of touch each other. And this is really just about a patient closes their teeth and they touch, and that is their maximum intercuspation position. The challenge with that is it has no reference to the conduit position, to where the condyles are. It really just has to be where the patient is comfortable with their teeth. So we call this the MIP position. Centric relation, or how we look at the condyles braced in their housing, is really about a bone-to-bone relationship. It has nothing to do with teeth, and I think that's where the kind of confusion comes in. MIP is about teeth, centric relation is about bone. If you want to put them both together, then it's called centric occlusion, and this is where we have the bone that touches and the teeth that touch at the same time, and they live in harmony together. And by the way, this is not the norm. 90% of patients do not function in this centric related type of occlusion. They really mostly function in an MIP, and that's usually where the damage is coming from, because they're not in harmony with the bone and centric relation. The other thing that you need to be kind of aware of is the lower jaw has a flexural rate to it. So that means every time your patient opens to a very wide position, the jaw actually has a little bit of a flex to it. And this is really why, especially with the lower teeth, you have so many more occlusal and contact issues, because the movement of the jaw, depending on the age of the patient, could be greater or less and can cause more movement or more challenges when impressioning that patient, especially with full arch type impressions. Okay, so what do I want? And I'm going fast because there's a lot of information here to squeeze in. One, I want the facial and functional harmony, right? So I want to accept that I put the incisal edge in the right position, that everything looks right in the face. But I also want the functional protective insurance. And I want to make sure that when the patient closes their teeth, that they don't have anterior interferences or functional interferences that are going to give my restorative problems down the road. So what do we call that? A mutually protected occlusion. What does mutually protected occlusion really mean? It means the posterior teeth protect the anterior teeth because they provide the stop. So I have a nice posterior occlusion, they stop, and they don't really allow me to hit those anterior teeth, because if I did, I could do some damage to them based on the angulation that they're in. Also, the anterior teeth protect the posterior teeth because the minute I make a movement and I go to a guidance, I'm guiding the teeth off the cuspids, which is known as anterior guidance, and I'm discluding the posterior teeth. The minute I disclude the posterior teeth, I'm shutting off the maxillary muscles, and they don't have the ability to squeeze and cause damage to the teeth. Now, I'm not going to go into a controversial concept here. I will just say that anterior guidance is quite very much overrated. Do I apply it to my cases? Of course I do. I utilize it on the articulator, but I can go back to studies from the 1970s up to today. Gibbs and Ledeen were some of the first people who did these studies, up until some of the Schweitzer articles and other references over today, that you would find that a person who's in a perfectly centric related occlusion, meaning their teeth and their joints are perfect together, almost never really utilize anterior guidance when they're chewing. So for us, anterior guidance is really just a articulator movement that we're kind of trying to protect our restorations and realize that we won't hit into areas that we don't want to hit into. And the reason that this is so important is because the jaw functions as somewhat of what we call a lever system. And the ideal scenario is the functional aspect of that joint is what causes the bracing point. The muscle is the force that kind of opens and closes it, and then the distance to the teeth is the working area of the lever. And if you kind of come over here and look at the lever systems, you'll notice that our lever system is really what we call a class 2 lever system. That means that that's where the fulcrum is, this is where the power is, and this is where the working mechanism is. If we change that to a class 1 or a class 3, meaning that the occlusion on your first molar is too high, well, you've now changed the fulcrum, and you've actually changed the person, instead of being a class 2 into a class 3 or possibly even a class 1. And those are very detrimental to the patient's functional ability and health. So really what I want in my occlusion is I want no real working interferences, and I want to make sure that I maintain my fulcrum as the functioning point of where everything should harmonize from, basically a class 2 lever system. Another simple way to look at that is when you're closing your articulator down and checking, you should have what we call dots and lines. This is an old school Dawson term. Dots and line meaning that when I check my articulating paper as I'm closing my articulator, I'm not getting big smudges or big drags on the occlusions of my teeth. And the only time I get those drags or those lines is when I move into protrusive and lateral excursions. So I'm really looking to keep what we call dots and lines to keep our occlusion kind of simple. Also, from a reference point, from a business standard or a clinical standard, if your doctors are spending a lot of time adjusting your restorations, well, that doesn't look good for you. The patient doesn't feel confident in the doctor, and then our relationship with the doctor suffers because they feel like they're doing a lot of grinding and adjusting, and part of them might feel like they're destroying the beautiful anatomy you made. Part of them might feel like, why do I have to work so hard every time I see the restoration, right? So for us, we want to kind of manage all those things. And for me, I try to manage this really very much in what I would call a correction base. When I'm finalizing my cases, I'm really coming back at the end and really maybe adding little dots of ceramic in my glaze to make sure that I'm getting the functional awareness that I want, so it harmonizes with the joint, the muscle, and with the occlusion. I don't want high spots. I want those dots and lines, and I want to make sure they're kind of an even, balanced dot and line situation. The other challenge that I think is focused here, or is frustrating here, is especially in our modern digital world, we're working most of our cases on these little digital quadrant models, and we're using a little quadrant digital articulator. And although that sounds great, and it's cost savings, and it's a kind of a quick process for us, the problem with that is we don't really understand occlusion. So if we take any of these, and I should probably update this photo and put some little digital models and articulators in there, But the point of it is that is not how the body works. So I did this experiment years ago. God, it must have been 10 years ago now, and I was teaching a lot more occlusion courses, but it's still a very accurate slide. Look at these two mounted models on the articulator, and notice that that area there is what we would call the fulcrum, or that is the condylar position of the patient. And like I said to you before, that fulcrum, then we have muscles, and then we have the teeth. Well, look what happens when I change the condylar position into a little plastic articulator or a little tiny articulator. I've actually changed the arc of closure, or the position of how those teeth actually interact with each other. So here you see that my center point is at the center of that articulator. So when I open and close, whether you do it from the top to the bottom, doesn't matter. That is the arc that gets created in my occlusion. But watch what happens when I change that point to the patient's mouth. Notice how different the arc of occlusion becomes. And this is why the doctors are spending a lot of time with adjusting the restorations, because you're working them from a plastic articulator. I still do that, and you can, but you have to be much more aware of the free spaces that are inside your occlusion to allow more room for that arc of closure as you go through. So here's the best example of it. You built up a very pretty molar, and you built it up on a little plastic articulator. And you'll notice that that hinge axis, or that center point of rotation, is right here. And when I close the articulator, it hits perfectly into that fossa, or into that groove. But when I deliver that to the patient's mouth, the hinge axis or the arc closes or changes. And now I'm hitting it in a much different position, hence why your doctors are grinding in the occlusions. So working on the proper instrumentation is king for us. We're using most of the time the Panaden articulators or the AD2 articulators, my friend Dave's company. Both of them are really great instruments. We use every articulator, by the way. I have Sam's and Stratus and Artex, so we have them all, but it doesn't really matter. We're following the same system for whatever articulator we are using, right? And the same system is we're mounting with a horizontal plane face bow, a coice analyzer. We're usually taking a CR bite, and the purpose of the CR bite is only when we're really doing full mouth rehab kind of cases, and then we're setting our pins to 0 to start. And as we work our way through the cases, we'll kind of work them through as a very kind of diligent process. So an example of that might be, we might make a little lucia jig here, and you can see in that lucia jig that my lower incisal edge is going to be hitting on the back of that platform. And that allows me now to kind of check my pin and say, okay, we opened the vertical 0.5 or 1 millimeter, and that's going to be the new vertical point that I want to work from. And once I have that vertical point, and I've checked that to the doctor's CR registration, I can now come back and say, okay, if that's where I'm starting, I'm going to wax in these second molars, and I'm going to check them both with the lucia jig and my posterior stop, that I'm actually holding shim stock on those areas. And once I've done that, now I can come back and say, okay, this is my vertical. This is where I'm going to work through on that entire articulation. And now I can build my entire wax up on that. And everything is checked with the shim stock at that point to evaluate that we're doing everything proper, and everything is utilizing the horizontal reference to make sure that we're getting the horizontal planes that we want. So we do have a very diligent system in how we do this to try to manage through the occlusal concepts. The one thing that I think is the topic of this lecture is, during that occlusal system, I'm really functioning on the envelope. And my envelope being that I know I have a bilaterally balanced occlusion. I've checked that with my shim stock paper. And now I want to make sure that I'm not getting any hitting on my lower incisal edge to the lingual of my upper incisal edge. I want to keep a little bit of freedom there, because most of the time that's where the interferences or problems will come from. So I want to make sure that I understand what the proper envelope is, and I want that envelope to be normal, meaning that my lower incisal edge functions comfortably behind that lower incisal, that upper lingual cavity. I don't want it to be too extreme, because that can cause what we call dysfunction, and I don't want it to be too tight, because that could be a constriction, meaning that the lower incisal teeth are hitting too quickly into the upper lingual concavity. And by the way, this is the probably #1 cause of failure in restorative that I see today is we're actually creating constrictions in our envelopes when we're working through our lower restorative teeth. The other thing I want us to be is good seers and good readers, right? And what I mean by that is, look at the pictures of these cases. When I'm diagnosing my way through a case, I can tell you the doctor may send me these photos and say, oh, I'm thinking of doing veneers on the upper. The patient wants pretty teeth. And I'm like, whoa, wait a second. That's not the way this is going to work. This is not a veneer case for many reasons, right? Look at the constricted envelope. Look at the wear on these lower teeth. So we need to functionally understand where that patient needs to be. And also look at the notches on the upper teeth. If I have those kind of notches, I don't have a flexible strength for the tooth, and this is no way going to be a veneer. This is going to have to be a full coverage restoration. So I want you to be able to read through the process as you're seeing these. And when you see these kind of cases, you should kind of have little red flags in your brain right away to think, what is the aesthetic parameter and what is the functional parameter? And a lot of times it's in the etiology of how the patient got to this point. Obviously, you can see that this patient had some restorative done, but look at the wear that's happening on that lower incisal edge already. And you can kind of see, just looking at the occlusal scheme, that somebody ground the entire occlusal scheme down, and now we're wondering why things are going to start chipping and breaking. You haven't balanced out the occlusion, right? So whatever your case scenario is, our job is to figure out what the etiology is, how the patient got there, and how we can improve them based on the aesthetic and functional parameters. Like a case like this, how do you fix this patient? Where does the incisal edge belong? Where is the lower incisal edge going to be behind the envelope? And how do we balance their occlusion out? And this is what we do in most of the cases that we work through today, right? We're taking a dysfunctional or a constricted patient, and we're trying to bring them into, one, where do the teeth belong in their face, and what is the proper envelope and functionality that they need. It's the same process for me over and over. The other thing I want you guys to be very aware of is, it's not always the functional aspect that causes the problems in the teeth. Sometimes some of these start out as functional components in your envelope or in your dysfunctional occlusion, and they turn into chemical related, meaning that once you've worn through some of the enamel on the teeth, sometimes a chemical component kicks in. And that chemical component could actually be saliva. It could be the pH balance of your body and your saliva, or it could be dietary. It could be the things you eat and the things you drink that are adding to the what you're seeing in the mouth. So I guess the point I'm trying to make here is, not every case is a functional problem. They could have been minute functional problems that became chemical problems. And once these chemical problems exist, you have more restorative coverage to do, because you have more tooth to now protect. So it may not be that it's a massive vertical opening. It may not be the function that caused other problems. It may be a secondary chemical component that challenges it. I'm actually working on a case like that now. This is my friend Dane's case out in Ohio. We just finished up the wax up, so I don't have any follow-up for you on this. But again, if you look at a case like this, as we work through the diagnostics, you can see that there is a functional wear that has taken place, but there is 100% a chemical wear. And you can kind of start to see those chemical wears, because as you get through the wear percentage, you start to get this washy kind of a softer look. So you'll have sharper edges, but very soft on the internal aspects. And this will be a real challenging case for us. So we did all the steps that we just talked about. We found our CR position. We decided how much opening vertical we needed to have. Where was the incisal edge position? All the things that we just kind of discussed through. And then Jennifer started our wax up here, and then Jen did a fabulous wax up on this case. And these matrix gets returned to the doctor, and he's actually prepping this case out tomorrow. So this hopefully maybe one of the next lectures I'll be able to show you the befores and afters of a case like this. But I just wanted to walk you through the process for us, meaning that incisal edge position, bilaterally balanced occlusion, and then the cross arch non-interference of where we're going. And in this case, I jokingly said, will Dr. Dane be prepping these or building these teeth up? And in truth, these are going to be minimally in preps for him, because he's going to probably have to build more of the teeth to get the support we need for the final restorations. Okay, I also mentioned anterior guidance, and it's a little bit of a challenging 4-hour subject that we could have. So rather than go too far into that, all I'm going to say is instead of anterior guidance, what I'm more concerned with in our patients is what we call the home position. And the home position is really a position where, as the patient is closing their jaws together, they usually have one point of contact. And that one point of contact is kind of an engram. It's a memory mass for the patient. And that memory mass is actually basically where they feel like they're at home, and that allows the teeth to kind of actually slide together. So the engram is a memory mass, and then the proprioception is the sensory point. It's kind of like you're just navigating yourself into that driveway. Why the engram or the home position is so important is because of what you see in these two slides. And I actually borrowed these two slides from John Coyce because it's very challenging to kind of create this environment and have the patient do what you need them to do. If you look to the left of your screen, you're going to notice that the patient has bit down and they found their home position. And I'm going to pretend that their home position was this distal cusp of the upper first molar. But once they reach their home position, they tend to slide and close the teeth a little bit more. So now look at the buccal cusp of that first molar and look at it here. And you're going to notice that there are two different kind of positions. And this is really important for us because let's pretend that you're restoring that upper first molar. Well, based on this first point of contact, you have more restorative space. But when the patient bites down, they hit that home position and then they squeeze the rest of their teeth together. Your restorative is now in the way. It doesn't feel right. And that's the term that the patient uses. It doesn't feel right. Something's hitting too early. And this is where you see the doctor adjust the restoration, grind down the restoration, and then send it back to you and say glaze. And you look at it and say, but this is not even touching the teeth at all. Well, it may not be touching on your articulator, but it is in the patient's mouth because the teeth compress and the periodontal ligament helps them to fit into the area that they want them to fit into. So it gets a little bit more complicated. And again, this is why working it through on the right articulator is really important. The other challenge that I'll just throw out you is when doctors try to take their CR bites or their MRP bites, really difficult for them. Patients are usually laying back in the chair, so the joint becomes a little elongated. It's very difficult to capture the true bite that the patient has. So what we'll do a lot of times is we'll use the provisional cast and mount that in MIP because that's become what the patient has worn their way through. And then we'll take a palatal index of that and use that palatal index to mount the full prepared model. This way we can kind of use something a little bit more reference. So what I'm really saying to you as a little trick is have your doctors give you full palatal casts and use palatal indexes to verify their bites, okay? Also, I told you we're transferring everything through a facial analyzer. So my facial analyzer is basically a Coyce analyzer, and this is much better to me than a full face bow. And the reason for that is because the face bow operates from the ear position, the auditory meatus, and has a reference point. And what tends to happen on your cast with a true face bow is you're getting this severe angle of the cast, where on a Coyce analyzer, you're getting a much flatter plane, which is much truer to the patient's point of reference. So I really want that reference point for myself to have the true angulation rather than this severe angle. You don't really see that. Also, that severe angle will affect my envelope of function, right? So when I come to my lower position, if my teeth are already tilted in and the articulator is kind of putting them in a weird angle, I'm actually getting a stranger angle in the envelope. So again, flatter plane on the Coyce platform, and that allows me to manage my way through. And then the last element of this is orthodontics. So sometimes when we're working with our patients, we look through our cases and we say, you know what? They are constricted. They're constricted because the lower incisal edge is either in the wrong position or has protruded up out of the arch, and they're starting to get wear and fatigue on the upper teeth, so the envelope is wrong. One way to manage that would be to open the vertical and get those teeth out of the way, but the other way to manage it is orthodontically, is to move the teeth where you want them to be. Now, in today's world, before we start moving teeth, especially retruding them or intruding them, you always want to make sure about the patient's breathing abilities. how well do they breathe? Are they snorers? Are they mouth breathers? They breathe through their nose. And these are things that are important to know before you just say, I want to move these teeth back and close off the environment even more. In this particular case, though, he's a nose breather, so it wasn't an issue. The jaw position was fine. It was really the tooth position that was problematic. So we basically are going to bring those lower incisal teeth back in and down a little bit and create a little room for us to have some restorative space. I'm also going to restore those lower teeth, so that'll give us a little bit more room to make them kind of fit into the environment that we want. And in the end here, this was actually a press case that we did. So we did everything through a wax and pressed kind of technique. I did my normal standard build-up, upper and lowers. And again, all we're doing here is worrying about that we've managed the incisal edge position. What is the functional bilaterally balanced relationship with the posterior? And did I create enough freedom in the envelope position? My friend Mark always does the Mark Wagensall, if any of you guys know, he's a denture guy in Canada, and Mark always says he does the wiggle, right? That they should have a little bit of freedom in centric. Well, I agree with Mark's concepts, and I think we should have not only that wiggle in centric, but we should also have that freedom behind the incisal edge position. So again, these were just a lithium disilicate case, upper and lower arches, after the orthodontics were done, and we finalized our case, and our patient functions a lot more normal now. And we managed all the little things that we talked about through our case. So with that said, I think I'm pretty cool. I'm actually very fast, so I left us a little more time than usual. I'm sorry I was going so fast because I wanted to squeeze a lot in, but that's good. Maybe we'll have some more time for questions. So I think you get the concept of when I talk about the occlusal envelope. And what that really means to me is, one, where does the incisal edge belong? Two, what is the horizontal plane of the upper teeth? And then three, the actual envelope of occlusion is where is my lower incisal edge position behind the upper teeth. And I hope it made it clear enough going as fast as I did that I don't want those lower incisal edge hitting hard into those upper linguals, that I really want some freedom there. And I want that freedom to be protected by the bilaterally balanced posterior teeth and to be able to shim stop through or pull some articulating paper through those lower incisal edges so I'm not hitting hard on the linguals of my restorations, okay? Hopefully I explained that well in a really short period of time. That's kind of a tough one, Jim, to squeeze into a short window, but I hope I answered all the basics, and maybe there'll be a few questions that we can kind of answer to tie it all together. Thank you guys for paying attention. Sorry I went so fast.
We have additional programs coming up all the time with Peter and various other key opinion leaders. And as I mentioned, all of these are recorded, so you can see any of these post-presentation if you need to on the VITA North American channel, YouTube channel. Hope to have you join us live so you can ask questions to all these. Peter's been gracious enough to provide us with the contact information. Peter does work in and out of country and has a lot of work, works late nights. So, you know, if you need to contact Peter, he's open to having you do so. However, you know, please be careful that you don't, you know, disturb him too much. You probably want to email him first and then maybe work out a time that maybe you and Peter can get together and discuss whatever is on your mind. So as far as questions go, Peter, we have one. Does the envelope of function work for all cases, or is it mainly for full arch cases?
Envelope of function should be for every case. So if a patient has a poor envelope, you want to be more careful restoring. Example of that would be you're only doing 6 veneers and the envelope is not a great envelope. The lower incisors are hitting hard on the upper linguals, and maybe it's not an ideal veneer case unless you address the lower incisal edge position or consider changing the vertical position or restoring.
All right.
Right?
Yep. And then do you try to create a anterior length? So I think it's described as more of, is there a target of the length of the crown that you try to achieve through your envelope of function? do you have any guidance or averages, I guess, of length of crown that should be exposed above the smile line or below it, however you want to look at it?
I think I know what they're saying here, and this is a little bit of a, so you'll have to bear with me on this answer a little bit. First off is, I always start off by the incisor ledge position. Where does the incisor ledge belong in the face? And I get it that that may be different in my opinion than somebody else's, longer or shorter. What I want to do though is evaluate that aesthetic point of view first. Once I have that aesthetic point of view, then I will come back with my horizontal plane reference and my envelope of function of what I can and can't do. Could I have to modify that incisor ledge position? It's possible. Obviously, in full mouth cases, no, I have control of it almost across the board. So I have the ability. The second part of that, though, this is why I said it's a little confusion, is how much incisor ledge is displayed has more to do, I think we teach this wrong, Jim, and I think I'm trying to answer their question fully. We've taught people that, well, when you lips in repose, you should show 1 to 4 millimeters of incisor ledge. Well, that's baloney, because it's baloney because it really depends on a few things. That person's lip dynamic. Do they have a high lip dynamic or a low lip dynamic? It also depends on their age. The younger we are, the higher the lip goes up. The older we are, the more the lip tends to drop. It also depends on your cosmetic awareness, meaning, are you Botoxing the lip? Are you red sealing the lip? Are you putting fillers in the lip? Because that changes the position of that lip dynamic. So realistically, the concept of using the old incisor ledge reference during repose, I think, is antiquated. And I would tell you that some people will just not show incisor ledge, even though they're 40 or they're 90, based on the alterations they've made to their lips and their facial features.
Okay, that makes sense, and it kind of follows into this next question or a comment that really form follows function. In other words, your envelope of function comes first, and the question is more of the form, the finish line. Was there a tolerance, that a leeway in which you can deviate from that envelope of function, that exact envelope of function? Is there leeway? And I think you kind of answered it in your comment there about different age representation and patient specific. Unless you want to add more to it.
I think that question is going in a different direction. Actually, I think what they're saying, and if I'm wrong, they can correct me. But of course, form follows function. That's a given, right? So I'm not creating form only from an aesthetic point of view and forgetting the function. Just the opposite. We're creating the basic incisor ledge and aesthetic positioning of the teeth, and then the form of the tooth. But yes, the functionality of that will determine the final. And what might that determination be? Well, I'd love to create beautiful lingual anatomy and have all the right ridges and lines for my movement. But if we're limited in space because we're only doing an upper arch, I might have to modify the thickness of the restoration, still incorporating the proper anatomy, but maybe not to the wear that I'd like it to be, right? Or maybe incorporating a wear facet on a tooth that I may not have had previously when I started the restoration on the lingual, meaning that as the patient's moving a right or left lateral movement, that they were hitting too hard on the lingual marginal ridge of the number 7, and I might want to flatten that so it's a more balanced occlusion or a balanced envelope that I'm working through in the anterior.
Okay, and then talking about centric contacts on the posterior occlusal contacts, for an ideal case, occlusal contacts relatively all come in contact at the same time, correct?
Yeah, so it's called bilaterally balanced occlusion. And that should mean that when you close your articulator and you're using that little shim stock paper, which is the best, or a piece of toilet tissue, that every time you close, you can grab one cusp and get the same pull on every tooth that you have. That would be an ideal bilaterally balanced occlusion. And that means when you deliver that to the patient's mouth, they should have the exact same premise, that patient bites down and they have a fairly even grab of shim stock or articulating paper. And the adjustments for that should be minimal, meaning that if you have one tooth that's hitting really hard, the more you adjust that tooth, you're going to start seeing the other teeth might have more or less contact. So it's really important to work that out as best as possible on the instrument.
All right, and then for a full case, I know you mentioned about the different articulators, but for an ideal, which articulator provides you with the best solution for most patient envelope of function?
Yeah, so I think, again, without sounding controversial here, I want the simplest semi-adjustable articulator. And why? And I think the Panadent, the AD2 are probably the two that we use the most, but the Stratus 200 and 300 and the Artex, they all kind of are simplified versions. Now, each of those companies make a fully adjustable articulator, but I would argue that it's really not necessary, right? Because you're looking for immediate side shifts and extreme, protrusion and excursive movements. I think it's a little overkill. For me, I think it's really more about the occlusal plane being in the right position and being able to check the lateral excursives and the protrusive movements. And you could do that with any good semi-adjustable articulator. And for me, the key to that is the table. And I think today, my friend Dave from AD2 makes the tables that I use for my occlusal reference point for every articulator. So it doesn't matter which one you're using anymore. You could use that same table on every articulator today, whether it's the AD2 or the Panadent or the Stratos or any of them. What I avoid using is the older one. I think somebody wrote me a note the other day saying, "Can you please mount this case on a Hanau or something?" And I'm like, I threw those all out 10 years ago, so no.
Must have been from the military.
Yeah.
All right. So you mentioned earlier some references. The question is, do you recommend or know of a book that's a good reference that they can learn more about this subject? I know there's snippets in every book, but is there a good book to understand this better?
Well enough. I think over the years, Schutz in Germany did a lot of writing on occlusal concepts, the occlusal table. I can't think of the guy's name right now who actually does Dieter Schultz, I'm sorry, who did the whole occlusal concepts. And I think actually Renford and some of the companies actually make the waxes today for those occlusal concept waxing, which is kind of cool. Besides that, we've had so many leaders over the years. Russ DeVoe was a hero of mine who passed away a few years ago, and a lot of people did a lot of work. I don't know if there's one specific that I could really walk you through and say this book has it all. Although as a COIS guy, I'm a COIS mentor, and I will tell you that we do cover a lot of occlusal concepts in the COIS program. So I always encourage technicians to go through the COIS programs because that's really where I think I harness my occlusal skills, even though I had taken Dawson and Pankey and LVI and OBI and every one of them over the years. I feel like I finally, the aha moment came at the COIS Center for me.
All right. And then last question, you mentioned about the COIS analyzer. Somebody's asking, do you know what the cost is?
Yeah, it's a joke. It's like $200-300. A Facebook for most of the good instruments is like $1,500 or $2,000, which is why most doctors always say, "Well, do I really need that?" A COIS analyzer is a must. I believe they're about $200-300, and again, they sell them through different companies. So Panadent sells them, and now AD2 sells them, which is Dave's company. And the beauty of them is they're a few $100s, and if your doctors refuse to buy them one. Give it to them, teach them how to use it, and then add a few bucks on their bill now and then to make up for it, because it's one of the most important tools, I think, especially in the aesthetic world today for us.
All right. Well, that's it for the questions. Thanks again, Peter. Any last minute comment before we close out?
No, I would just say it's a rough thing, and I went really fast. I'm sorry, because it's so much to talk about with this concept. It's a really rough subject to kind of put together in a quick 1 hour webinar, right? Because every one of these topics I can go on to for 2 hours to talk about, and we still won't learn everything we need to know. I know I don't know enough on all of them, but I appreciate everybody tuning in every month that we do these, and thank you guys for watching, and I hope you got some useful information out of this.
Well, thanks, Peter. I know I did, and I'm sure that the audience did as well. Again, you can visit the recording of this on the VITA North America YouTube channel. That'll be posted here in a couple of days. Again, Peter, thank you very much. As always, it was great, and I look forward to the next webinar with you. And as now that this will conclude today's webinar. Thanks for joining, everyone.
Thank you, everybody.